Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here with Professor Amir Kashani of the Wilmer Eye Institute of the Johns Hopkins University School of Medicine, where he is Associate Professor of Ophthalmology. Amir, welcome back to Retina Synthesis.
Thanks, Carmen. Thanks for having me. It's great to be here.
Today, we're going to talk about a topic that's near and dear to both of us, which is OCT angiography, and particularly OCT angiography in its wide field form. Can you tell us a little bit about what OCT angiography is for those members of our audience that may be unfamiliar with it?
Of course. So OCT angiography is one of the most recent iterations of OCT technology that is available both in spectral domain and swept source. And basically, the technology allows you to visualize movement of particles, red blood cells specifically in the tissue, by repeating the OCT scan multiple times, 2 or more times, depending on the machine you're using. And basically, if you repeat that OCT scan multiple times in the same section, the backscatter from it varies if it hits a moving particle versus a non-moving particle, so that you can see red blood cells moving. And by doing that, people have been able to generate very nice maps of the capillaries and the larger vessels in the retina. And just like regular OCT, it's depth resolved. So you can actually look at the different layers of the retinal vasculature and the superficial and the deep and the choriocapillaris, and even out to the choroid nowadays with the swept source devices that have deeper penetration. And it's really just changed the way I think we look at retinal vascular disease, everything from neovascularization to neovascularization elsewhere in retina, retinal diseases, and in choroidal neovascularization in diseases like AMD. It's changed the way we look at those diseases.
What are the common applications of OCTA?
Common applications, I think, is really any vascular disease of the retina. I mean, the ones we see most are diabetic retinopathy and age-related macular degeneration. So those, you can't go through a retina clinic without having, half dozen or more of each one of those at least. And so that's really where it matters most. For diabetic retinopathy, the wider field, which I think we'll talk more about today, is more relevant, perhaps because you want to look for neovascularization in some cases. But even the macular scans are very important because you want to see how much macular ischemia there is to judge what the visual potential is. In neovascular AMD and other kind of choroidal diseases, the application is very useful for looking at very subtle areas of choroidal neovascularization that are hard to detect on fluorescein. And myopic CNV is another application. And so, uveitic CNV is another one. I think it spans everything, retina.
So there's been increasing interest over the last number of years in looking at the periphery in retinal vascular disease, particularly diabetic retinopathy and vein occlusion. Can you comment on that trend?
Yeah, so I think that the knowledge base we have of those diseases was largely based on the 7 ETDRS fields and the areas of non-perfusion from those fields on either fluorescein angiography or just the fundus photos. And when we started doing ultra wide field and wide field fluoresceins, we realized there's so much more going out in the periphery. And it's hard even on those ultra wide field fundus photographs and fluoresceins to always tell what's going on in the periphery or even in the mid periphery. And sometimes the fluorescein angiogram is just not something you want to do or can do on those patients. So the interest in OCT angiography and looking at the peripheral vasculature is twofold. One is we're finding out things are going on out there that we didn't realize based on either the inavailability of FA or the lack of resolution of fundus photos. And two, it's showing us, I mean, it's just easier to perform, right? I mean, you don't need dye injections, it's cheaper, and I think it's more cost effective. So I think there's a twofold interest. One is just financial and common sense, practicality of having a trained photographer to do an FA versus an OCTA. Two is the disease processes are more involved in the periphery than we thought. And I think that's something we're starting to realize with wider field imaging in general, OCTA specifically for vascular diseases.
So what are the technical requirements for wide field OCTA?
Well, I think speed is one of the most important things. The speed of systems is what limited the earlier versions of most devices from creating wide field, because the faster you can scan, the higher the resolution, obviously. And you need a certain, if you're going to look at capillary level changes anywhere, or you're going to look at small vascular changes, you need to have the resolution at around capillary level resolution. So if you can't scan fast enough, then it's not going to help to look in the periphery, because you're just moving a small field out to the periphery. But now that there are 100 kilohertz systems, 200 kilohertz systems, and obviously prototype versions that are much faster than that, but commercially there's 100 and 200 kilohertz systems that are available, spectral domain and swept source. And so those allow 8 to 12 millimeter fields with fairly good resolution in the 25 micron range. That is really the rate limiting step. Obviously, montaging those and having kind of the software expertise to put those larger images together is another technical hurdle. And the last technical hurdle is probably to make sure that we are accurately representing the peripheral anatomy correctly. And that's a little bit of a challenge, but I think there's still so much we can learn with the technology that we have that it's fantastic.
What, in terms of the number of degrees of visibility, what degrees are we at?
We're at anywhere from, with OCTA specifically, I think we're at anywhere from, you want to say 30 to 40 degrees with just your 8 millimeter scans, to upwards of around 100 degrees with your 12 to 15 millimeter scans. And then if you montage those, you're probably out in the 125, 140 degree range with some of the montages. So in terms of OCTA, you can get that far out reliably. There's some devices that have peripheral line scan capabilities for OCT. You can kind of move a line scan. It's not really OCTA yet, but I think it's starting to get there in the far periphery. But right now, you can get to the mid periphery or even a little bit farther, just doing some montages.
So, how do you evaluate eyes and with diabetic retinopathy yourself?
So, for a patient coming in for kind of a annual screening exam, just mild non-proliferative diabetic retinopathy, I will just get a OCT angiogram. Because that gives me information about the severity of, actually, for any diabetic coming in, I just get an OCT angiogram of the macula for sure. And because that gives me information on whether there's macular edema, which you need to know nowadays, because subclinical macular edema is ever present. And we have to decide whether to treat it. But then you want to know how much non-perfusion there is within the macular area, because it gives you a sense of the severity of the disease. There's tons of studies, including from our own, and we were one of the first to show this, that if you look at the central capillary density in the central 3 or 6 millimeter scans, that correlates very nicely with the overall severity of diabetic retinopathy. So you get a 3x3 or 6x6 millimeter scan, and you see capillary dropout that's noticeable. You should be thinking this patient may have more than mild or more than minimal NPDR. Doesn't mean they do, but maybe they're on their way there. And the other thing I do, if I have any suspicion that there's peripheral disease, like neovascularization, a wide field, like a 12x12, I'll get pretty standard on a patient or at least an 8x8, to look for areas of neovascularization. There are a couple of nice studies that show if you look at 12x12 millimeter scans, which are commercially available now, centered either on the nerve or on the fovea, you can catch 90% or more of new NV in patients without previously diagnosed PDR. So still want to do your DFE exam. You may or may not want to consider doing a fluorescein after you get that OCTA, but really you can catch the majority of neovascular disease and diabetes with an OCTA and a good examination.
What about evaluating the peripheral non-perfusion? Are you using that as a decision-making tool?
You mean in what sense? In terms of doing like injection?
Looking at the extent of non-perfusion to decide whether or not you're going to initiate anti-VEGF therapy, for instance.
I don't really use it in that way. I think it's good to know the severity of non-perfusion or the magnitude of non-perfusion. But I don't think that, I still use anti-VEGF based on, either the presence of neovascularization or PDR or macular edema or severe NPDR, kind of the traditional indications. I don't really try to treat based on areas of non-perfusion. I think some people perhaps have tried to look at whether there's benefit of targeted retinal photocoagulation in the context of peripheral non-perfusion to prevent neovascularization or to minimize the burden of laser treatments. I'm not sure that works as well. The literature is a little bit controversial. Some people say targeted peripheral laser may be helpful. Other people say, it's not effective. But I think one thing I would like to try more of, and I'm kind of in the process of doing that, is for patients who have proliferative disease and have areas of low risk proliferative disease with neovascularization, and you're treating with anti-VEGF, it might be a good idea to use OCTA to identify areas of neovascularization and treat locally around those, because now you've got the anti-VEGF on board and you can locally treat neovascularization and see if that minimizes the burden of laser therapy. I don't know if there's any evidence to say that actually works or adds benefit to either one, but it may be a way of doing targeted laser or targeted treatments in the way I think you suggested, but not really mainstream. I don't do it mainstream.
How often do you do wide-field fluorescein angiography?
I still find myself doing it often. If I have a suspicion that there is neovascular disease or a patient who is poorly controlled and severe NPDR, I think there's a lot of patients out there who have severe NPDR that have proliferative disease, but we're just not detecting that subtle NV yet. So if I have a wide field OCTA available to me, I'll do it. And if there's no NV on that, and I'm very suspicious, I will still do a wide field fluorescein angiogram to rule out any farther peripheral NV. Don't want to miss that 10% of people that have farther peripheral NV. I think there's a role for FA. I don't think it's it's going to be banished from the face of the planet, but it's not cost effective. It's hard to do, relatively speaking, especially at satellites. And so I think it's kind of more of a secondary resort. Certainly as a first-time exam for a new patient coming in, one FA at baseline, I don't think hurts just to get a evaluation of the overall disease. But after that, you're not following patients with FA anymore these days.
What about vein occlusion?
Vein occlusion, I think, falls in a similar category. I think it's a little bit easier to look at vein occlusions, especially if they are sectoral, like branch vein occlusions, using OCTA, because you can actually, target your imaging to that area, and you don't necessarily have to get the whole periphery in view. But yeah, I think in the same way, you can look for subtle neovascularization in vein occlusions. You can also see macular edema, all with one scan. I think it's even less necessary to do fluorescein for vein occlusions than it is for diabetes, especially if you have good wide field OCT angiography, because where the pathology is clinically, and you just want to see if there's subtle neovascularization or if there's macular edema, or how much non-perfusion there is if you're going to do the PRP.
And pediatric retina.
Pediatric retina, I think, is a blossoming field in terms of OCT angiography. There's some people who are doing really nice work on peripheral Widefield OCT in pediatric retina, looking at areas of where's the ridge in ROP, and looking at the development of the retina in early kids. But I think that the role of OCTA in those diseases has to be developed. I think there's definitely going to be a role there, and it makes a whole lot of sense in especially pediatric retinal vascular diseases. The question is, do you have systems that can actually do it reliably? And that I think has to be worked out. But definitely an ROP and peripheral vascular diseases in kids, I see a major application, because again, injecting fluorescein in kids is even less ideal than injecting it in adults.
What manufacturers have wide field OCTA?
I think I don't want to leave anybody out. We use the Zeiss Plex Elite a lot in our group. There is also a Topcon system with a wider field of view, and I guess I'm sure there's other vendors. I don't use them regularly, so I don't know, but those are the ones that I'm familiar with, and that's kind of the field that I'm aware of. Certainly for FDA approval in the United States, I think those are probably the only two systems that have FDA approval in the United States for a system with OCTA capability.
Well, Amir, thanks so much for your overview of this exciting topic. Things are changing.
Yeah, they are, for the better, I think.
Yep, great. Thanks for your help.
Thanks, Carmen. Appreciate it.